Hello, good morning, good afternoon, and good evening to all our speakers, shares, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from India, Professor Matthew Joseph. Dr. Joseph is a stellar figure in neurotrauma and neurocritical care at both national and international levels. He is a professor in the Department of Neurological Sciences at Christian Medical College, Vellore. He is the chair of the Neurocritical Care Wing of the Indian Society of Critical Care Medicine. He was the past secretary as well as past president of the Neurotrauma Society of India and is also a current member of the Neurotrauma Committee of the WFNS. We are extremely honored to have him today at our webinars, and today he'll be talking about brain death certification. The speaker for the second session of today is our honorable guest from China, Prof. Li Ye. Dr. Li is currently an associate chief neurosurgeon at the Suanwu Hospital and executive director at the Center for Brain Trauma and Intracerebral Hemorrhage at the Capital Medical University, Beijing, China. He serves as the secretary of the National Quality Control Center for Brain Injury Evaluation and Beijing Neurosurgery Quality Control and Improvement Center. He is also a member of the trauma group of the 7th Committee of the Neurosurgery Branch of the Chinese Medical Doctors Association, the Smart Medicine Committee of the World Chinese Medical Doctor Association, and the Precision Neurosurgery Technology Committee of the Chinese Research Hospital Association. We are extremely honored to have him today at our webinars, and today he'll be talking about recent advances in surgical strategies and clinical research on intracerebral hemorrhage. The chair for the first session of today's webinar is our honorable guest from India, Prof. Ishwar H.V. Prof. Ishwar is the professor and former head of the Department of Neurosurgery at the Sri Chitra Tirunal Institute of Medical Sciences and Technology, Kerala, India. His clinical practice focuses on surgery of brain and spine tumors, vascular disease, and intraventricular endoscopy. He is also running a pain clinic along with his anesthesia counterparts, attending to non-cancerous patients. He has won several accolades for his meritorious contributions to neurosurgery, including the Best Doctor Award. He has received special award from the Chief Minister of Kerala for his contribution to facilitating organ donation for brain dead donors in the state. He is also a noted author with several publications in various period journals, and we are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from the UAE, Professor Florian Roser. Prof. Roser is the chair of the Neurological Institute at the Cleveland Clinic, Abu Dhabi. He was the previously vice chair and chief of staff of the Department of Neurosurgery at the University of Tübingen, Germany. He completed his residency at the prestigious Department of Neurosurgery, Hanover, Germany, and he holds the position of full professor of neurosurgery at the Faculty of Medicine at the Eberhard Karls University of Tübingen, Germany, and he serves as the professor of surgery at the Cleveland Clinic Lerner College of Medicine at the Case Western Reserve University, Ohio, USA. He is also adjunct professor at the Biomedical Engineering Faculty at the Khalifa University, Abu Dhabi. He is editor-in-chief in the journal Clinical Neurology and Neurosurgery and associate editor for the World Neurosurgery. He has authored over 107 peer-reviewed articles and 18 book chapters, mainly as first or senior author, and we are extremely honored and grateful to him for chairing the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this online podium to our first chair, Professor Ishwar.
Thank you, Dr. Raja. And it's indeed an honor to be there chairing a session for furthering the cause of education as the ACNS does it every month. I've been part of this teaching sessions in the past too. And today's topic definitely touches the hearts and minds of a lot of people, especially in kind of terms of the number of people's lives that we can save, even with loss of one life, and that is organ donation following brain death. Brain death has been one of those difficult topics, at least in our part of the world, because brain death is something which even physicians are not exactly aware of. When they talk of death, we always talk about cardiovascular death and not brain death. It's simple, for the simple reason that any person whose heart is beating is still considered as being alive, not just by the population at large, but also by even the physicians who are not aware of what is brain death and what is the status of the neurological status following a grievous head injury which causes brain death. Okay, now there are, like Dr. Matthew Joseph has been trying to dispel this erroneous perception among medical fraternity in India by organizing various classes for neurosurgeons, neurologists, and critical care specialists about brain death certification, especially the steps that are involved, each of them to scientifically prove brain death so that There are no questions or doubts in the minds of stakeholders involved, especially the families of people who have come forward to donate the organs of their dear and near ones, and also the other doctors who would sometimes be afraid and kind of little hesitant to come forward and do the certification that is required prior to a person being serving as an organ donor. Of course, always remember that there is delight in death, and that is to help the living. With these words, let me hand over the mic to Dr. Matthew Joseph, who has played a stellar role in India in propagating brain death certification and organ donation. Over to you, sir.
Thank you, Ishwar. Given that this is an Asian thing, I've tried to keep the talk country neutral, but some bits of India centric are going to creep into my talk. I apologize for that in advance, but I'm sure some of the things that we face would be faced in other places in Asia as well. So I'm not trying to make it completely country neutral. Okay, so to declare somebody brain dead, you have to be sure the coma is irreversible and then prove the absence of brainstem function, including apnea. So the first thing is you must know why. You must know why the patient is potentially brain dead. This patient, who incidentally was the first patient I declared and organs were transplanted in 1996, we have no hesitation in continuing with the process of declaration of brain death. Whereas this patient, I would be very, very wary of trying to declare brain death. You must make sure there is no external cause for the impaired brain function. No drugs, no metabolic problems, no hypoxia, no hypotension, no hypothermia. Any of these would make the brain at that point dysfunctional, but it is not irreversible. You correct these conditions and the patient might recover brain function. So make sure none of these temporary causes are there before you say the coma is irreversible. Having done that, then you come to the brainstem function. Okay, this is a standard list of the 6 things you have to do. Practical points in this, you don't have to have dilated pupils. Even if your pupils are mid-sized and not reacting, that's fine. When you do your oculocephalic or doll's eye testing, it involves abrupt movement of the head. Make sure your ET tube is anchored. I have actually practically done this myself. I rapidly turned the head to one side and the ET tube went the other way, and I was left with an apneic patient with no ventilation. When you're doing caloric response, remember to tilt the head up 30 degrees because that enhances the strength of the response because your lateral semicircular canal becomes vertical. I generally don't bother to use a suction catheter down the ET tube. I just jiggle the ET tube itself, which is a very strong stimulus to make the patient cough. For those of you who are beginners, an easy way of remembering the testing you have to do is 2 eyes, which is pupils and corneal reflex, 2 ear, which is oculocephalic and caloric response, and 2 throat. Easy way of remembering that if you need a mnemonic. The last test we do is the apnea test. The reason we do that last is, generally speaking, except for primary brainstem injury, all neurological deterioration takes place in what we call the craniocaudal deterioration. So if you look at the list of tests, it's midbrain, upper pons, lower pons for the vestibular nuclei, medulla, and then you come to apnea, which is the lowermost medulla. Anywhere on the way, if you find that there is brainstem function, then you don't do the remainder of the tests. Okay. The other reason we do the apnea test last of all is all the testing before this causes no physiological or any other harm to the patient or to the body itself. The apnea test, you will be causing hypercarbia, you'll be causing low pH, which if the patient is not brain dead, could harm the patient. If the patient is brain dead and you do it improperly, you might actually harm the organs. So apnea test is the last and final clinical test to do to declare somebody brain dead. Before you do the apnea test, make sure the temperature is adequate. Two reasons. One, like I said earlier, a low temperature will falsely make the brain dysfunctional. The second is your apnea test depends on the carbon dioxide going up. Carbon dioxide is generated by metabolism in the body. When the patient is cold, there is very little metabolism. And you'd wait 10 minutes and your carbon dioxide wouldn't have gone up sufficiently and your apnea test will be indeterminate. So make sure the patient is as close to normal temperature as possible, because that makes the chance of your getting an adequate PCO2 higher. BP should be adequate, obviously, because the brain is not perfused, then it will not function, which is not a fair test. Fluid balance positive is something we learned on the way. We've been doing this now for almost 30 years, and we lost a cup. Everything I say is based on lost potential donors. If your patient is not adequately filled, doesn't have enough volume, carbon dioxide is a vasodilator, not just in the head, all over the body. So as you raise the carbon dioxide levels, all your blood vessels in your body dilate. And the patient was barely adequately filled. When this vasodilatation happened, your cardiac output goes too low. The cardiac return is low, and therefore the patient will hypotense. So make sure the patient is well filled before you do your apnea testing. The procedure itself is you provide oxygen at the carina. All right. Depending on the condition of the lungs, you could do an oxygen catheter, a vein circuit, or you could use the ventilator itself. So before you start, let's assume you were ventilating the patient at 35. What I do is when we start doing the brainstem testing, that is the pupils, corneal reflex, etc., just before that, I will increase the FiO2 to 100%, and I will reduce the ventilator rate by 2 or 3 per minute. What I'm trying to achieve is make the patient hyperoxic, which makes my apnea test, make my apnea test easier. And I'm trying to bring my PCO2 up to say 40, 45, which means I need less of a climb to reach the 60, which is declared a positive apnea test. So just as a practical cheat, if you want it, this is how we do the thing. If the lungs are good, what we do is just put a suction catheter into the carina, not too far in, not too far out, because you want the oxygen to be delivered at the carina, and put a low flow, 4 liters, 6 liters, somewhere around there. What you're trying to do is fill the large airways with 100% oxygen and allow the oxygen to diffuse further down, and therefore keep your oxygen saturation up in the blood. If you put too high a flow, then oxygen actually, you will start ventilating the patient. You will start washing out carbon dioxide, and your apnea test may not be successful. So don't put high flow oxygen down the carina, because that will interfere with your carbon dioxide buildup. If the patient's lungs are not good, all right, and you need some amount of PEEP to maintain the lungs and the oxygenation, then we use a Bain circuit. We just hold it, keep the pressure slightly up, and proceed as usual. Wait for as long as necessary. The additional advantage of this is because you're holding the Bains in your hand, any breath the patient takes, you'll feel the bag move in your hands. For the very severely patients whose lungs are very bad, we sometimes use the ventilator itself. We set the rate and say 4. We maintain the PEEP. We set a very low rate, and then see if the patient overbreathes the ventilator, allow the carbon dioxide to come up. This gives you the additional advantage if you have an enteral carbon dioxide monitor. You actually know how much carbon dioxide has come up, and you can do your blood gas sample at the correct time. One caveat in this is, remember, these patients are usually in a hyperdynamic situation. The heart is beating really hard because you've probably patients on multiple vasoactive drugs. And in this situation, if you set your sensitivity too low, say 2 centimeters or 2 liters flow or whatever it is, the cardiac activity itself might trigger a breath. So make sure you set your sensitivity a little higher so the cardiac cycles do not trigger your ventilator. Okay. So whatever it is, whichever technique you've used, the timing is a little difficult to say. We usually come in around 6 or 7 minutes, but it depends on the patient, depends on the temperature, depends on the starting carbon dioxide, depends on a lot of other factors. A positive test is if the PCO2 crosses 60 millimeters mercury, and the pH will naturally be less than 7.3, and the patient doesn't breathe. A negative test is the patient breathes. An indeterminate test is the patient doesn't breathe, but you don't achieve your target PCO2, in which case you'll have to repeat it after an hour or two. If the blood pressure drops, if the saturation drops, if the patient develops any cardiac arrhythmias, you have to abort the test because as you will not be able to proceed. Practically speaking, one, make sure your hand is on a patient. Somebody's put a hand on the patient to look for breathing. This again, we did. We had a patient who was very unstable blood pressure. So we were cheating by giving small boluses of pressors to the patient each time the BP came down. And all of us are looking so hard at the monitor and fiddling with the blood pressure pumps, with the pressor pumps. It took quite some time before we noticed that the patient was actually breathing. All right, which shouldn't really happen. Also, don't think that you need 60. Sometimes the patient can be very stable, and I've had my juniors come to me and say, I got a PCO2 of 84 on the apnea test. As if they should be congratulated for getting such a high value. Okay, it is not appropriate. If the patient hasn't breathed at 60, the patient is now going to breathe. And 84, all you've done is damaged all the organs and made the chance of a successful transplant less. You don't want your PCO to go too high. Okay. Excuse me, I've got a bit of a cough. Anyway, the essential part of this entire procedure is you must have a protocol. All right. It should go from everything, from the time the patient comes into your ICU, when you test, how to manage you have major problems with fluid balance and the blood pressure. When are you going to do your testing? The entire process should have it written down because you may be there for some time, but you don't want to be there every time. And your personal change, at all levels, doctors, nurses, whoever it is, regulations may change. So you need to make sure everything is writing, and this has to be constantly revised. I wrote my first protocol in 96, and I don't know what version I'm on, probably version 20 by now. But it's essential to have a written protocol. So if you look at ours, we have from the beginning each of the metabolic causes, the brainstem testing, how to do the apnea test, make sure the temperature is okay, BP is okay, positive fluid balance, the methodology, when to do the test, how to interpret the test, and how to record the values. Everything is there in our protocol. You just have to go step by step and make sure you don't miss out anything. Which is not saying it replaces experience. There is a learning curve on this, but the protocol, a written detailed protocol, actually helps you slightly flatten that learning curve. Indian law says you have to do 2 tests at least 6 hours apart. I don't know how it is in different countries. The US has come down to 1 test, single test. But in all cases, whether they agree to donation or not donation, whenever you stop the treatment, the time of death is always the time of the second positive apnea test. By law, that is the rule. Okay. Now, India, the good thing about our brain death criteria is it's purely clinical, which means you can do it even in hospitals which don't have fancy equipment, massive angiography plants, etc. They don't have, but we can still do it. The bad thing about it is it's purely clinical. The reason I say this is you're supposed to do clinical testing for brainstem function. If the patient has, very often our injuries are two-wheelers. Somebody's run his face into a post or a tree or whatever it is. Okay. his face is badly injured. Can you check pupils? No. Can you check corneal reflex? No. Can you check oculocephalic? No. Can you check caloric response? No. Are you going to declare a patient brain dead based on just absent gag and absent cough? Difficult. Yeah. Or basic skull fracture, say, involving the labyrinth. You may not have functional vestibules. Then how do you check all the things that depend on the vestibule? All right. So these are problems. Apnea test. Somebody has spinal cord injury and has a bad head injury. Or the chest is so bad that you cannot do an apnea test properly. Then how do you declare the patient brain dead? Okay. The World Brain Death this thing said with the consensus guidelines. Basically, what they said is use clinical. If clinical not possible, use ancillary. All right. Ancillary test, the gold standard is a 4-vessel angiogram, show that there is no intracranial circulation. Transcranial Doppler in the correct hands is useful. Radionuclide scan is used primarily in Australia and New Zealand to show an empty skull. There is no radionuclide uptake in the head. Now, Indian law has no mention of ancillary tests. There are case reports of this being used, but what the legal implications are for not completing your thing, the form itself does not have any place for mentioning ancillary tests. So this is a slightly gray zone. Not that we will not use the ancillary tests, but it's never really been challenged. The legality has never really been challenged yet. I don't know what will happen when it does happen, when it does get challenged. Right. So, there are many, many ways you can not have a donor come through to donate. All right. And what I've talked about so far, the inability to test is one definite cause. We want to minimize all these causes because every donor is precious. Now, again, I'm going more local than universal, but for us, a donor is in an ICU requires a lot of attention. And sometimes, so much attention comes on the patient that other patients may not get the attention they deserve. We have, our medicine is largely self-funded. So a family comes in, if you tell them, listen, there's absolutely no chance, they'll say, okay, we'll take him away. Should you hedge your bets and say, we can try, even though you know this patient is not going to survive, it becomes a little bit of a, ethical issue. Similarly, if you write, these people are usually low income. If you write off the bill, is it a financial inducement? You say, listen, you donate organs, we'll write your bill off. Is that a financial inducement? Expensive. Testing and this thing is expensive. Where there's no state-funded care, who pays that bill? Yeah. For the ICU itself, in the neuro ICU, this patient is a dead patient. They are not going to see any rewards for treating this patient. It's a lot of extra work with not very much reward. Keeping your junior doctors and nurses engaged is sometimes hard. All right. And remember, organ donation or declaration of brain death has to be done as soon as it is viable. It's not an office time job. It could be at 2 a.m. It usually is at 2 a.m. Yeah. Because the longer once somebody is brain dead, the longer you keep them on a ventilator, the more unstable they become. And the higher the risk of losing the organs. Therefore, you need to keep your team everything has to be there all the time. All the facilities, all the testing, all the personnel, everything has to be there all the time. Which is again hard in smaller institutions. So I work in a very large hospital, so it's not a problem. But smaller institutions, that can be hard. I have not mentioned anything about donor management because my topic is declaration of brain death, but this is extremely important. Okay, this is where the learning curve comes in. If you cannot maintain your potential donor, you can be in really big trouble because it's an extremely dynamic situation. If you're not be careful, your patient will put out 1.5 liters of water in 1 hour, urine in 1 hour, and crash and arrest before you know what's happening. You understand? Your normal ICU protocol of hourly urine output will not work here. You got to do every half an hour, every 15 minutes, whatever it is. And there's a whole lot of things. I'm not going into details, but this is learning curve. So similarly, with the volume comes maintenance of blood pressure. These are the two biggest challenges for a donor, all right? A potential donor is maintaining adequate volume, maintaining adequate blood pressure. Okay? And it is there is a learning curve involved, and there's a huge amount of you have to pay attention. You can't really leave the patient and go off somewhere for any significant length of time. So I'll stop here. Basically, donors are precious. We have a huge mismatch between the number of organs needed and the number of organs actually available. You understand? So every donor has to be identified, tested, and uh, convinced to donate. We should not ever have this situation for any prolonged amount of time. All right, this is a cartoon from the BMJ. Yeah. Thank you.
Thank you, Dr. Matthew Joseph, for elucidating all the medical as well as the technical aspect of brain death certification from an Indian perspective. I'm sure that there will be a lot of questions from this audience, as always. And in the past, I have seen Dr. Matthew Joseph answering all those questions very patiently. I'll set the ball rolling with one question. Many a times a patient is on an ECMO machine, extracorporeal membrane oxygenator. In that situation, how do you do the apnea test? Because I don't think it's practically possible to do the apnea test.
Yeah, no. My colleague, I think you met her, Dr. Shalini, actually gave a talk on this at the last ICCM meeting on brain death declaration on ECMO. All right. It is hard. It is very hard. There are no laid down
There are
criteria.
real situations in our practice. It is being increasingly, ECMO is available in our country also in many parts of the world, which
Yeah.
means that a lot of patients are hooked to it when they are brain dead.
Yeah. So bring the carbon dioxide up is hard in ECMO. And then ECMO patients usually deeply sedated. You have to take off the sedation, which is not good for the patient. If they're muscle relaxing, you have to take off. Oh, it's extremely complex. I've never had to do it so far personally. And I have only 6 months of work left before I retire. So I don't think I will have to, hopefully I will not have to do it. But yeah, no, that's a very complex question. There are book chapters, there are all kinds of things on how to do brain death testing in ECMO, but it's not something I'm an expert on. So I won't say. All I know is it is very difficult.
Another question which always runs on the top of our minds is whenever we are not able to perform a test, we rely on an ancillary test. What do you think is your favorite ancillary test when it comes to, an extra help using a test to, make sure that, all stones are not left unturned in our quest for.
Yeah. So I'm lucky in that I've got two very good sonologists working with me. All right. Very good. They are really expert. So my go-to test is if the patient is very stable, I will take down for an angiogram. But if there's any doubt about the stability, if I'm on more than one on vasoactive drug, I will do TCD. I will do TCD and record. But that is because, again, I said I'm lucky. I have two good people with me whose word I will rely on. You understand?
Yeah, the problem with the TCD is it is operator dependent. So you're lucky to
Yes.
have somebody who does it very well for you. The problem is the difficulty in insonating and finding out the flow in the anterior cerebral artery, middle cerebral artery, and the internal carotid artery. It's not an easy thing to achieve.
No. So our protocol is when the patient comes in, any potential donor comes in, PCD is done immediately. So we know that there's a flow.
Yeah.
And then when the patient becomes brain dead, we can demonstrate the same place lack of flow. That's part of our protocol is that we do TCD at admission.
Okay. Thank you.
Yeah.
I think
But otherwise, I would say angio. I'm not sure how good a CT angio is. There is, literature is not very clear about that. CT, how good a CT angio is as replacement for an actual four vessel angiogram. literature, there is plus and minus. So I'm not quite sure how to go for. We go for the direct angiogram.
The problem with CT angiography, with the ease of doing CT angiography definitely is appealing. Unlike a catheter angiography, where you have to have a radiologist available to perform the test by making a cut down on the femoral artery and introducing a catheter and trying to cannulate and see presence of contrast in all the vessels. CT angiography definitely is inferior to catheter angiography, but it's again one of the most favorite things for all of us in our part of the world. But there are times when the interpretation of an angiogram becomes difficult, especially if you have a external ventricular drain, or if the patient has been subjected to a decompressive cranectomy when the intracardiac pressure is low. There is a phenomenon called as the stasis effect, by which the contrast, instead of flowing along with the blood, there is a phenomenon called a stasis effect. It kind of draws into the brain's blood vessels and creates a false positive. This is problems that we have confronted when we do a CT angiogram. And also there are concerns about the CT angiogram because of the contrast that is injected, which can definitely compromise the renal status, the status of the kidneys, and therefore preclude a person from being a kidney donor. So all these are questions about the angiography test. Of course, the difficulty is that you can't get a good sonologist to do the sonogram and identify the blood flow in the internal carotid artery, the middle cerebral artery, and the anterior cerebral artery. I think I'm happy to take some questions on behalf of the audience. If there are any questions.
Sure. We'll go ahead and invite our panelists. Dr. Liu, any questions from you?
Yeah, thanks, Professor Joseph. I remember you came to Malaysia before, many years back, and I think you are one of the neurosurgeons who are now practicing fully in intensive care, which are good model for many countries, and where we should have a neurosurgeon in charge of intensive care. My question to you, Professor, regarding brain death, which is supposed to be a clinical test per se based on the guideline, how do you determine that the best time to do a brain stem test in a patient with prolonged barbiturate coma? I think I do not know what test to do to determine that the effect of barbiturate won't be there. And second thing, I would like to ask that regarding unstable patient in terms of hemodynamically or electrolyte abnormalities. So which parameter you think is the most important to enable you to do brain stem test, or all parameter must be normal? I think this is also another problem when we want to do a brain stem test. A certain value may be critical, a certain may not. My last question, Professor, which type of patient that you think that brain stem test should not be done? For example, patient with neurological diseases, motor neuron disease, or some in form of intoxication that we could not detect. We do not have test kit to ensure that the patient not intoxication, or patient even in severe COAD, the PCO2 level may not be difficult to determine. So in which patient you think that in your practice you would not do a brain stem test? Thank you, Professor.
Okay. So going in order, barbiturate, I think if I had given barb coma with one of the long-acting drugs, I would probably not test, because I have seen patients who were given thiopentone for seizures wake up after 8 days, remain comatose for 5 days, have minimal movement for 2 days after that, and then wake up and be normal. All right. So if somebody had been given thiopentone or one of the long-acting barbiturates, I probably would not attempt to declare brain death there. Of the things that metabolically what you would do, I would say the most important are the first, not metabolic so much as systemic, which is adequate blood pressure, adequate oxygenation, and adequate temperature. And given all that, which any good ICU should be able to maintain all those three, I would say the single most important parameter for brain function would be serum sodium. I would give sodium more importance than everything else. Not that potassium is not important, magnesium not, but sodium has an outsized effect on neuronal function. All of us know hyponatremia and the patient is comatose, having seizures, etc. So I would say the single electrolyte I would concentrate on primarily would be sodium. And what is the third question? Sorry.
Which pathology that you not perform?
Right. Yeah. So I would be, as I said in the beginning of my talk, I would be very uncomfortable trying to declare brain death for somebody who didn't have radiological evidence of an intracranial catastrophe. Okay. If there is big bleed, huge edema, effaced cisterns, whatever it is, massive midline shift on the CT scan, which is compatible with a diagnosis of brain death, I would be very happy to, I mean, not very happy, but I would be comfortable declaring brain death. If I had a scan which showed me mild abnormality or no abnormality, no matter how clinically convincing it is, I would always suspect that there was some other cause that I have not detected. In a sense, suppose you have a normal scan and the patient is clinically brain dead. I don't think I could, swear that there is no toxin or medication or something the patient has taken, which is, I cannot swear that it is not there. So I would primarily require evidence of a catastrophe in the head. Then I would be okay declaring brain death.
Including patient with neurological diseases, which are scanned usually normal.
Dr. Liu, I think.
Yeah.
Can I answer the question, Dr. Matthew Joseph, with your permission?
Yeah.
It's like brainstem encephalitis. You have a locked-in syndrome. You have a medical problem like a motor neuron disease. Should not be considered for brain death at all. In brain death certification, Dr. Matthew says the first slide was identifiable cause for a grievous hurt to the brain should be there. Neurological diseases are a strict no-no for brain death declaration.
Unless you take large infarcts or large intracerebral bleeds as neurological conditions, that's fine.
They are neurosurgical conditions also.
Yeah.
Thank you.
And also about this toxicity, this question that you had raised about the toxicity. If you are suspecting that the patient may be under the influence of some drug or this thing, it would be practical to wait for 5 half-lives to pass so that the drug's effect on the brain would have receded by the time you're certifying. And also, when you suspect that there has been some poisoning or something like that, it is better to do a toxicological screening, a forensic toxicological screening before you embark on brain death certification. I think that answers most of your questions, Dr.
Yeah. The problem is, in India, there are very few good toxicology screens.
Yeah, that is true. But the ideal thing would be to subject the patient to a toxicology screening.
Yeah. Ideal thing is if you have any doubt, wait.
Yeah.
Yeah, especially when could not identify the agent, the drugs. How long do you think that the best time to wait? 1 week, 2 weeks for unknown?
It's very hard. If you talk about 1 week and all that, that is a phenomenal utilization of your ICU resources. I don't know if you live in a place, work in a place which has unlimited ICU available, but it's an ICU bed tied up, it's number of staff tied up, and your patient is getting more and more unstable because the longer the patient is brain dead, the more difficult it is to maintain the blood pressure, more difficult it is to do everything. Then your infections come in to complicate the issue. Now the blood pressure is dropping. Is it sepsis or is it, it altogether becomes very hard. What I've generally found is if we don't manage to declare somebody brain dead in the first 5 days, we rarely succeed. Yeah, it has to happen in the first 5 days.
Thank you, Professor.
Yeah, we have Dr. Pirsnath from Afghanistan who has raised his hand with a question.
Pirsad is the head of Afghanistan neurosurgery. Yes, Prof. Please unmute your mic.
Hello, Assalamu alaikum. Thank you, and for our Muslim brothers, Eid Mubarak. Thank you, Professor Joseph. We are facing like this brain dead cases many times, and also in Afghanistan as well. And do you recommend EEG for testing or not? And second, when brain stem reflexes are absent and there is brain death, but the heartbeat is present. And when we disconnect the ventilator and announce brain death for patient relations. Thank you.
Okay. So, answer to your first question about EEG. EEG, especially in an ICU environment, is quite unreliable. All right. There are too many technical things that could cause your EEG to be isoelectric or indicate brain death. So EEG is not generally recommended as your first ancillary test. I mean, you can't do an EEG and declare somebody brain dead. From the second thing, once you've got absent brainstem reflexes, all right, that is, you've done everything including apnea, and the patient is brainstem dead. Again, I don't know what law is in your country, but in our country, only one state, which is Kerala, has given the doctors the authority to disconnect the ventilator. In the rest of India, technically speaking, it's stupid. When you look at it, it's really stupid, but that's the way the law is written. That is, you can actually take out the kidney, take out the heart if the patient is declared brain dead. But you can't take off the ventilator if they don't agree to donate organs. Our law is declaration of brain death only for harvesting of organs, not for discontinuation of treatment. Only one state has, the state is a health is a combined function of our state and the central government. Only one state has put out a rule saying once the patient is declared brain dead, the patient is dead. You can take off the ventilator. You cannot, the family cannot insist on the ventilator being maintained. In the rest of India, you could declare the patient brain dead, and if they agree for organ harvesting, you take out the organs. If they don't agree for organ harvesting, you can't take off the ventilator, which is a stupid rule. But that's how the rule is written right now in our country.
Thank you. Thank you very much. Shukriya.
Well,
Eid
that's
Mubarak.
very interesting.
Eid Mubarak.
Well, I would ask like few questions to Prof. Matthew Joseph that we have had several issues in brain death certification. Of course, Prof. Ishwar is that like on call for everybody. We ask him, give a call emergency, so what to do next. But I would like to ask you about most certain problems we have had in the past is about pupils. When pupils are like not really dilated, we have had problems when our seniors have gone in the first time and they have come back and said that the pupils are not dilated. You call some other guy few hours later. So like when we go again, it's difficult to convince them because somebody very senior has gone before us and told that pupils are not dilated. So this is one of the main features. But when I went to the literature, and also as you mentioned rightly early in the talk, that pupils are not really, the size is not that matters really. Another thing is about temperature. What is the temperature that do you look for? Is it the core temperature or the peripheral temperature?
So we put a, okay, the first thing, yes, I agree, except when the pupils are pinpoint and becomes difficult to say something, unless you've got a pupilometer. Pinpoint pupils are difficult to check on this thing. And we do a temperature with a probe in the esophagus. We don't do axillary. I think we put a probe in the temperature probe in the esophagus, and we measure temperature there.
Okay, like one instances that when we went and the temperature was not okay, and they gave a patient a warmer, just blow up the warmer full, and after like 15 minutes the temperature is back. So like, is it really a solution for that?
No, we use patient warmers. We generally don't use warmed IV fluids and things like that, but we do use patient warmers quite frequently. And I think the main thing is to make sure the patient remains covered. Yeah, we cover if the patient had surgery and the head is shaved, we cover the head and basically have just the face exposed and the rest of the patient covered. And patient, no, 15 minutes, I've never seen a low temperature come up normal in 15 minutes, but over a couple of hours, yes, it does work.
Right. Thank you very much for clarifying that. If you have any further questions, Prof. Florin Roser, How is it in Abu Dhabi? Would you like to comment?
Yeah, I would have a question because the brain death regulation is different from country to country, right? So some countries accept brainstem declaration as brain death, and others needs to be whole brain death, and that's really a challenge, right? Depending on which jurisdiction you live. And then the second point you rightly mentioned is that what happened after the declaration, right? Like in Europe, it is law to disconnect end-to-end therapy, right? Because if you declare somebody brain dead, you're not allowed to continue. And in other countries, you declare brain death, but then it's a decision of the family whether to continue care or not, which again is problematic in terms of resources spent. And I think it's really important that the communities, the countries, us neurosurgeons work together with the legal authorities and the regulators, right, to get a common understanding what is needed in terms of resources to declare brain death or brainstem death. But if you look over the last 3 or 4 decades, how far we are, I think we came a long way. So I'm very optimistic and looking forward.
Thank you very much. I think we can take the final remarks from our chair before we wind it up.
Thank you, Dr. Matthew Joseph, for an illuminating talk on. And one of the few people in the world who's got maximum number of experience in terms of certifications. Dr. Matthew Joseph is an apt man to give a talk on brain death certification. He has come up with a lot of special techniques when you are in doubt or when there is some confusion, and he goes around India talking about it also. Thank you, Dr. Matthew Joseph, for participating in this meeting and enlightening us on all these key steps in brain death certification. I know there are hundreds of questions on this one because the jury is still out on what is ideal brain death certification, because there are a lot of situations where a person cannot be sure about, in spite of experience of over 100 cases on brain death certification. But then there is need to come up with a very credible form of brain death certification that does not leave any doubt in the minds of all the stakeholders, especially the relatives of the patients, the laws of the land, as well as, of course, the critics of brain death certification, because there are a lot of moralists out there who say that brain death certification is not actually moral, and for several reasons which we cannot elucidate at this point of time. Thank you very much, ACNS, for coming up with this topic for discussion.
Thank you, Ishwar. Thank you, ACNS, for inviting me.
Raja, and once again,
I'm not sure. Ishwar, you're frozen. Are you saying something? Your camera froze. That's why I started talking.
No, I'm sorry.
Okay.
Sorry. You can.
Yeah. So thanks for inviting me. I'm not sure if that is a recommendation anybody wants, that I have declared more patients brain dead than anybody else in the country. Yeah. Even though it's true, I'm not sure if that is something you want to hear about yourself or not. But anyway, thank you. Thank you, all of you.
1996. You started it in 1996 when we were still not, neurosurgeons yet. That's pretty long.
Well, thank you very much. It was indeed a very enlightening talk. Thank you very much. I would like to inform all of you that this has been broadcasted on WeChat, YouTube, and Zoom. Thanks to Professor Shubin. And as of now, we have around 940 people who have logged in through different channels or around the world. So thank you very much, Professor Matthew Joseph. Thank you very much for joining. It's a pleasure to host you again, sir. Thank you very much.
I would love to hear the next talk. It looks very interesting.
So we'll go into the second session. I'd like to invite Prof. Florian Rosa to say a short introduction.
Yeah, thank you very much. So indeed, the 2 lectures are of crucial importance to the neurosurgical community. And specifically with recent advances in surgical strategies and clinical research of intracerebral hemorrhage. Next lecture by Professor Lee. Well, when you look of what has been published over the last years, right, there are different areas in terms of ICH. One is minimal invasive surgical techniques. We all remember the ENRICH trial or the MySitch trial, where we compare, endoscopic surgery, burr-hole or stereotactic surgery, and navigated aspiration with lysis, or the standard craniotomy for hypertensive supratentorial ICH. Very good data on these trials. There's, of course, meta-analysis coming up, so that is an important aspect to discuss. Then we have, of course, technological innovations in ICH management, whether this is robotic-assisted surgery or neuronavigation-guided surgeries, new tools like the tube system, for example, the fiber-sparing approaches. Then when you look one step beyond in terms of rehabilitation after ICH, there are a lot of advances, right? Regenerative medicine, stem cell implantation, and so on. And the last part, which we might discuss depending on the upcoming lecture, is personalized medicine, predictive analytics, like machine learning, outcome prediction. These are all available through these online open public databases we have, like the MIMIC database. In my journal, I get a lot of submissions now from the MIMIC database, which is an open available database for critical care. And then with machine learning modules, we have really very good predictive values for ICU readmissions risks in ICH patients. So it's a very, very crucial topic. I'm very happy to announce the next lecture about the recent advances in surgical strategies and clinical research on intracerebral hemorrhage by Professor Lee, that he's very well published in that respect. So the floor is yours without further ado.
Okay. Thank you so much for introduction. So it's really a great honor for me to have the opportunity to share, to discuss ICH today. And Ye Li, a neurosurgeon from Xuanwu Hospital. So today I would like to talk a little bit about the recent advances in surgical strategy and clinical research on ICH, and especially advancement in surgical treatment for ICH, focusing on timing and minimal invasive techniques. So first, Xuanwu Hospital is the actually the National Center for Neurological Disorders, and our department of neurosurgery was established in the 1960s in Beijing. So it is now recognized as the Chinese training base for neurosurgery in China, and we warmly welcome you guys to visit Beijing someday. So as we all know, China has the highest stroke prevalence in the world, with the stroke being the leading cause of 45 million deaths in the country, and more than half of which are attributed to ICH. So over the past few decades, neurosurgeons has been dedicated to exploring the efficacy of surgical interventions for ICH. So the stage 1 and stage 2 trial demonstrated that conventional craniotomy did not confer significant benefit over medical management for ICH patient. And subgroup analysis suggested that potential functional improvements with early surgery for lobar hematomas. However, these findings lack statistical significance. And a primary concern was that surgical injury might offset the benefit of hematoma evacuation. So consequently, research shifted towards minimal invasive surgery is misapproach later. So given the limited surgical studies available, the 2015 guideline concluded that the surgical intervention offered no clear advantage for ICH patients, and the efficacy of missed hematoma evacuation remained uncertain. So between 2016 and 2019, two missed studies indicated that the catheter placement combined with thrombolysis could reduce mortality in ICH patients. However, these approaches did not yield significant functional improvements. So similarly, studies on intraventricular hemorrhage surgery reached comparable conclusion. So in light of these findings, the 2022 guideline underwent a notable revision, recognizing ICH as a surgical condition. So they recommended surgical intervention when hematoma volume reached a certain threshold, as it can clearly reduce mortality. However, the impact on functional outcome remains uncertain. So this uncertainty has led to a stagnation in ICH surgical research. So if surgical intervention only reduce mortality without improving functional outcome, they may impose substantial burdens on patients, on families, and healthcare system. So this promoted us to investigate why these approaches have not yield functional benefits. So upon analyzing previous RCTs, we have hypothesized that the delayed surgical timing might be a contributing factor. So for instance, in stage 1, the average time to surgery was 30 hours post-onset. In stage 2, it was 27 hours. And in the MISTI-3 trial, the average time was 47 hours, almost after 2 days. But in contrast, actually, Chinese approach to ICH management differs due to cultural and ethical factors. So there's a more proactive attitude towards ICH surgical treatment, with a cultural emphasis on preserving life. So additionally, the government has established a network of stroke centers across the country. So it complete with stroke maps and annual evaluation. So this infrastructure ensure the rapid response and treatment, making China well positioned to conduct research on optimal timing, surgical timing for ICH. So we all know that in 2024, there are 3 significant studies on ICH surgery were published, highlighting the potential functional benefits for this endoscopic procedure. The ENRICH trial, published in the in New England Journal of Medicine, compared endoscopic surgery to best medical treatment, and found that the endoscopic intervention improved the utility-weighted MRI score. It's not the traditional MR score. It's utility-weighted MR score in patients with lobar hemorrhage. And also, the ENRICH study employed an adaptive design, ceasing enrollment for a deep ICH patient after their interim analysis, which showed no significant benefit, while they still continually recruiting patients with lobar hemorrhage, which kind of patient demonstrated clearly improvements on functional outcome. So similarly, the MIND study, initiated by another endoscopic company, stopped their enrollment after a ENRICH publication. So they also reached a similar conclusion. So about the deep ICH, the SWITCH trial focused on deep ICH, utilizing decompressive craniotomy without intracerebral surgery. So its hypothesis was that deep hemorrhage combined with cerebral edema-induced ICP elevation, so that leading to poor functional outcome. So the results provided limited evidence that decompressive craniotomy plus best medical treatment might be superior to the best medical treatment only in severe deep ICH cases. So this is the ENRICH trial. They are using brain path and mirror devices and using the utility-weighted MRIs. It's not a typical functional outcome evaluation method, but it's easy. This kind of method is easy to get positive results. So there are also 2 additional endoscopic study, Evacuate and Mira, sponsored by Integra using the Aurora system. That they are underway, so we eagerly anticipate their findings. So these developments have addressed several key questions in ICH surgical research. So first, should the hematoma be evacuated? So the answer is yes. Evacuation can improve patient outcome. The second is what is the optimal method for evacuation? The answer is minimal invasive technique, including catheter drainage and endoscopic surgery. They are preferred. But the third question is, when should the hematoma be evacuated? So this remains an open question and requiring further investigation. So we all know that the American Heart Association guideline updates every 7 to 8 years. So during this interval, several surgical studies have been conducted or are in progress. So they all emphasizing strict control over surgical timing and mainly sponsored by endoscopic companies. So these underscores that the importance of determining whether surgical timing influenced functional outcome in ICH patient. So some single center study have explored the correlation between surgical timing and functional prognosis. So in 2021, Professor Christopher Kellner from Mount Sinai Hospital utilized their Penumbra, Apollo, and Artemis system for hematoma aspiration and irrigation. So his research confirmed that the delays in surgical timing correlate with diminished functional outcome. And also Professor Daniel Hanley from Johns Hopkins, the PI of the MISTY and CLEAR trial series, suggested that in the review that ICH surgical treatment might be benefit from adopting research models used in the ischemic stroke interventions. So currently, the pressing question is how to select appropriate patients for surgery, comparing techniques, and also precising timing for surgery. So if surgical timing is indeed correlates to patient prognosis, it is imperative to explore the underlying mechanisms, as suitable animal models are still lacking. So in Asian countries, particularly in China, emergency medical services may operate more efficiently than those in Western nations. So therefore, conducting research on surgical timing for ICH in China is both actually meaningful and feasible. So in summary, the optimal timing and surgical window for ICH interventions require further study. And additionally, the impact of different surgical techniques and hemorrhage locations on postoperative outcomes warrants investigation. So also, the infratentorial ICH represent a distinct research area with numerous unresolved questions. So actually, driven by our commitment to advancing ICH treatment and addressing national healthcare need, we have established a high standard research-oriented ICH ward in the Department of Surgery at Shenhua Hospital. So our research focus has involved from exploring potential studies to align with national priorities. We are concentrating on the generating high-level clinical evidence through RCTs on surgical treatment for ICH. We are also planning for multi-center recruitments. And the second is we are promoting adaptive technologies for ICH based on real-time monitoring and data, because we are also a national center for quality control for neurosurgery. So we have the national data and the real-world information. So we are also conducting fundamental research on immune regulation in ICH using the biosamples, imaging data, and clinical informations. And then we also developing medical engineering innovations such as surgical robots, and I'll show that later, and leveraging our ICH imaging database and clinical resources. So our ultimate goal is to reduce the disease burden of ICH and enhance the quality of life of our population. So in our research-oriented work, we offer various treatments for ICH and collaborate efficiently with ICU and the rehabilitation team to ensure comprehensive life cycle management for patients. So clinically, we here demonstrate a case with where surgical robot assists in neuroendoscopic hematoma evacuation. So during this procedure, robots aid in precise localization, calculating optimal trajectory and depth, and so that's how we do the navigation and meticulously plan the bone flap. And then we use the robotic guidance for accurate puncture. Here we are using a contact endoscope, so we can introducing the endoscope under direct visualization. Then after, so we can see we're introducing the endoscope, and once the hematoma cavity is accessed, so we remove the obturator from the endoscopic shaft, and then allowing for these kind of shafts, allowing for biomanual operation to evacuate the hematoma and achieving hemostasis using bipolar coagulation. So the robot arm can hold the endoscope, and we can use our bimanual operation. One is the suction, the other is bipolar. So after we get into the hematoma cavity, we first aspirate the liquid component and gradually remove hematoma mass. So for some former clots, the endoscope forceps are employed. And we can see that the robotic arm stabilizes the endoscope, providing a consistent field of view and freeing both hands for effective hematoma removal. So that's we routinely do the operation. So the postoperative imaging confirmed complete hematoma evacuation, and the incision diameter is minimal. And the other thing is our medical engineering research aims to enhance the automation for ICH surgical robot across the three stages. We are working on the embodied intelligence surgical robot for ICH, and the most important 3 steps for this kind of research is first is surgical planning, and then the navigation, and then the execution. So traditional surgical planning is time consuming and varies significantly across different doctors, different people. So it hinders the standardized treatment. So in order to address this, we have developed AI-driven automatic surgical planning for ICH. And regarding surgical execution, the current robots have limited interaction and collaboration abilities. So it often requiring additional personnel and increasing labor costs. So we are integrating mixed reality human-computer interaction technologies to improve the collaborative ability of ICH surgical robots. And furthermore, the neurosurgical robots only offer navigation and assistance, the holding the catheter or the endoscope. It lacks automation and coordination. So we are developing the automatic drilling and catheter placement technologies. So the goal is to enhance the timeliness of ICH interventions and promote standardized treatment across various hospitals, thereby advancing the medical equity. So we can see in this surgical planning video in our preliminary study, we have successfully utilized AI for automatic surgical planning, reducing the process to almost 10 seconds. So this system accommodates various hemorrhage types and will be further refined by incorporating expert experience to enhance the planning efficacy and accuracy. So moving forward, we will further incorporate the expert experience into our automatic planning system to improve both its efficiency. So to address the issue of limited collaboration in current system, we have integrated mixed reality technology. That's leveraging its high level for interactivity with the high precision of surgical robots. So this combination is aimed at enhancing the collaborative capacities for ICH surgical robots. So we also have developed automatic drilling and the catheter placement technology. We have the customized drilling and have been designed with a specific focus on preserving dural integrity during the drilling process. So our next step is to integrate all the key technologies to systematically evaluate the safety of auto drilling guided by intelligent surgical path navigation. So furthermore, we will explore strategies for autonomous drilling and catheter placement, and based on surgical intent recognition and parallel coordination for multimodal information inputs. So in conclusion, as we stand at the intersection of clinical need and the technological possibilities, our mission is clear: to redefine the surgical treatment of ICH through evidence-based innovation. By advancing surgical timing research, integrating the intelligent automation, and enhancing interdisciplinary collaboration, we aim not only to improve the survival, but to restore meaningful, functional, and dignity to our patients' lives. So we truly believe that with the global dialogue and shared commitment, the future of ICH care will be both smarter and more equitable. So thank you so much for your attention. I look forward to your insights and collaboration. Thank you so much.
Yeah, thank you very much, Dr. Lee, for this exciting talk. Really opens up your mind, and we all get a lot of ideas how that can look like in the future. There's one participant that wants to ask a question. Can I open the floor?
Yes, Dr. Farhad Ahmed.
Thank you, Dr. Rajat, for giving the floor. I had a question. Wonderful presentation. As you know, Bangladesh is a very populous country. We often get too many intracerebral hemorrhage cases in our day-to-day practice. So what is the basic clinical or ICH score? Do you use ICH score protocol to categorize the patient or take the surgical decision in case of surgical management?
Yes.
Do you have the ICH score protocol? Another question is, in case of we get ecosprin-induced hypertensive bleed, then what is your protocol of surgical management if the patient was using ecosprin or that is clopidogrel?
So thank you so much for the question. So first, we do use ICH score, but not routinely. Actually, the ICH score is quite a little bit complicated than the GCS, but we still use NEES as the routine evaluation, and we also use the MRI score. So we actually register every patient to our clinical research. So the ICH score is not actually a routine score for our clinical work, but it depends on the research, what kind of research you want to use. But according to the guideline, they still use GCS as the criteria for operation. So I'm sorry for the second question is.
My second question was clopidogrel, patient taking antiplatelet drugs and also having intracerebral hemorrhage. How will you approach to do the surgery?
The drugs kind of. I'm sorry, the microphone is not quite working for me right now.
No, like dual antiplatelets, integralin,
Yes.
Plavix. So how do you manage this? If somebody comes in and you have to take care of someone who has dual antiplatelets like aspirin, Plavix, Brilinta, integralin.
Yeah. Okay. So we routinely check their coagulation test, kind of like warfarin, the INRs. Actually, there's quite strict exclusion criteria for the operation. But I think aspirin, first using aspirin is not the we could operate on aspirin patients. the patient using aspirin. But for other patients, like using like have the blood, problem or other coagulation problem, there's no, we don't choose operation. The only best medical management is okay. But in China, the family, the patient's life is not depend on themselves. They depend on their family. So they always want the best treatment for this kind of patient. But I think surgery is only one of the choice, but not always the first choice or the only choice.
That is an important question because I appreciate Dr. Farhad, because dual antiplatelets or the new oral anticoagulative drugs that become more and more frequent, it's much more difficult to reverse them. So, for example, tranexamic acid has been proven to help, right, in the acute setting. Aspirin is not so much a problem. We start doing routine brain surgeries or ICH under aspirin. But the NOACs, for example, the new drugs, they are much more difficult to reverse and to handle. But tranexamic acid helped in the OR setting. It's a very good available cheap drug which anesthesia can give. I want to, Dr. Lee, I want to challenge you, right, with this beautiful lecture, but I want to challenge you. So I would believe from the 900 participants today, not everybody is as lucky as you and me working in institutions who can provide this type of research, robotics, navigation. But when you look at the resources of what you need for that minimal invasive surgery at nighttime, most of the time the ICH comes at night, right? You need 4 hands, like 2 surgery, you need navigation, you need a robot, it's expensive. We know the Artemis device is expensive. So when I look at all the trials in ICH over the last years, it becomes a little bit like the spinal topic in intracranial, right? It's all industry driven, and they all make us believe that their tools and equipment has better outcome. And it always compares to the standard craniotomy. And trust me, if we do a very small craniotomy frontal, and you barely need a spatula, right? You do a very small corticectomy, which is not much larger than what you do with an endoscope. You go in with a suction, you remove the clot, you can do it alone, doesn't cost you anything. And then the outcome is not dependent on the size on the craniotomy. I mean, we should all agree on that, right? It depends where you're going through or what the GCS score was before you took the patient to OR. But to just completely focus on the outcome based on the technology, that's a little bit too easy. Industry doesn't like us want to believe that, but it's true. So tell me what you think about these new technologies, which is great, and I think we need this in the future. But 80% of the world population, most likely most of us here on the screen, don't have access to that. So what's your recommendation for all of those who don't have access to these fancy things?
Thank you, Professor. It's a really, really a great and good question. Actually, we do the clinical practice based on all the evidence, the high level evidence, right? So minimal invasive surgery is good, but most of them are sponsored by the companies, by the industries, right? So actually, we routinely also do the microscope under the microscope. Do the transsylvian fissure. We split the sylvian fissure to open the sylvian fissure and get to the clot to do the microscope hematoma evacuation. So I think it's a good technique, and I think I'm quite familiar with that kind of technique. But if there's a microscope company that sponsor me to do the research, I can also do that to compare the the microscope scope removal of the hematoma compared to the best medical management. But actually, I think comparing different technologies is like from the ischemic stroke research. They also compare different technologies to withdraw the clot in the arteries. So I think the final question is, I don't think technology defines the outcome. I think time is the most important reason that define the outcome, and we are working on that to verify our hypothesis.
Yes, and I'm glad you say that,
yes.
because when you look at the different studies, 12, 24, 36 hours, I always ask myself, right, as a neurosurgeon, we all know the moment you think about doing something, you should do it, right? Because when you consider and then you wait, and waiting in general is something which never really improves outcomes. So that is a research topic I would like to see more, and I'm grateful that you take this on. There's one question from one of the from Afghanistan, Dr. Pirzad.
Hello. Thank you very much. My question is, beside to evacuation the hematoma, are you recommend coiling or clipping endovascular approach as well, or not at the same time?
You mean the edema after the hemorrhage, right?
Yes.
So yeah, I think it's a question or the answer to our the previous question. I think time is most important. If we wait too long, the edema is going to be enormous. It's not under control. But if we can remove the hematoma very efficiently, or in a very timely method, I think the edema is not a big problem. I can see that result in every patient than myself. Yeah, edema is only the time, because hematoma is there, the pressure is there, the ISP is elevation, the venous drains is not good. There's a lot of reasons that cause edema, but the only reason I think is time. That's my point of view.
Thank you.
I like to mention that you just said it's all about time, but I think more than the time, it is also about the location of the hemorrhage and the patient also. Like we all know about the enriched trial you spoke out, but if you just go back and read about that in detail, you will add that this trial does in no way represent the population that we come across in our practice. Okay, so first, this trial cannot be generalized, because although this is the only positive trial by Professor Gustavo Pradilla, who was our previous speaker at the ACNS webinars, he showed that this is a positive trial, and of course he showed the brain path neuronavigation also. So for this trial, they screened 11,000 patients to get this population of 300. So it is just around 2.6%, which you cannot generalize to the study that we get. So only 2.6% were actually eligible, and the patients should have a premorbid MRS of 0 or 1, and more than 80% volume was excluded. So were the basal ganglia hemorrhages. So the rest of the patients only were good patients with a lobar hemorrhage who presented within 24 hours. So you cannot really have such patients in clinical practice. As Professor Rosa rightly pointed out, the resources are not there in every place. Of course, the patient comes in too late in several low-income countries to the hospital. So I think rather than stating the timing, the location of the bleed and the condition of the patient, premorbid condition, is also very important, I think.
Sure, yeah, I quite agree. I think enrich is a trick. So it's a adaptive design. They use utility weighted MRI score. So everything they have done to want to reach a positive results. So, yes. but for RCT, positive results is quite important. So I kind of agree, but I think enrich trial is really a trick. Yeah.
Yes. We have Professor Luis Borba, the president-elect of WFNS, with us. Prof. Borba, welcome. Thanks for joining. Any comments from you?
Sorry, but I missed the presentation.
It was
I came too late.
Okay.
I watched the record.
Sure.
I call. Sorry.
I'll send it to you. Thank you very much for joining. Anyhow.
Hello, Florian. How are you? Good to see you. So when I saw the topic today in the morning, so I tried to connect it. I was too late. I'm very sorry. But congratulations, has a wonderful job that you are doing. See, ACNS today is the leader in education in the whole world. See, and the ACNS make the difference not only to the Asia, but to the whole world. Thank you for the wonderful job you are doing. Thank you, Professor Cato, that is the leader of this great organization. Thank you. Wow. And sorry.
Thank you very much. It means a lot coming from you, Prof. Borba. We have two more raised hands. Yes, Dilshad first.
Yes, thank you so much, dear friends, colleagues, and Dr. Yeli. I was just interested in the point of during the procedure of minimal invasive evacuation of the hematoma. Do you use thrombolytic drugs routinely in case of evacuation, or post-operative? Do you put it on the drain?
Yes. So we routinely do minimal invasive technique like catheter-based insertion, and we also use, in China we routinely use urokinase, not RTPA. Which is quite expensive. In China they only use for ischemic stroke, but for the intracerebral hemorrhage we use catheter-based insertion, and then we inject the urokinase for thrombolysis. Yeah, we routinely use that. Mm-hmm. I heard that in Europe, like Swiss, they also use urokinase. Years before.
Okay, thank you.
Yes, Biswas.
Hi, Raja sir. Good evening and Eid Mubarak. Can I ask you two questions? My first question is, sometimes we have patients with primary ventricular hemorrhage with hydrocephalus. So what is your approach? I mean, I want to know how to manage the hemorrhage, hydrocephalus, and is there any role of hybrid approach doing the catheter angiogram and find out the cause at the same time addressing the hydrocephalus? This is number one question. And number two is, sometimes we have very large ICs medial to internal capsule and lateral to internal capsule. So what is your approach to those patients, definitely which are surgically indicated?
So with the patient with that have also have the hydrocephalus, we routinely do the EVD for this kind of patient. Also place the catheter to the hematomic cavity, and that's our. But we divide for the deep hemorrhage, for the deep ICH, we divided the location to three kind of for the trajectories. The first is located at the like basal ganglia. We use the frontal approach to put the catheter because it's external capsule. So we avoid the pyramidal tract, right? So we do a frontal approach to place the catheter. But for the thalamic ICH, we use the parietal approach. This kind of approach that we avoid the we go internal to the tract, avoid to harm the pyramidal tract. And for the lobar hemorrhage, we use the most the possible for the catheter placement. And also so that's also the second question for the internal capsule and for the external capsule.
Yeah, I just wanted to know what's your DSA? Do you do DSA in case of primary ventricular hemorrhage after putting the EVD? Do you wait for a couple of days or you do it immediately?
Probably waiting is best. I think.
But the most important thing is, I think, in my opinion, the volume of the ICH is not the most important thing. The ICP is the most important thing. The pressure is more important than the ICH volume. Okay. So we That's why.
Right. Thank
Okay.
you. Thank
Thank
you
you,
very
sir.
much. We come to the end. We'll go back to our chair, Prof. Florian, for his.
Yeah, so listen, I believe we could discuss for a long, long time, right? Because you have many trials, many new evidence, and that is one of the few topics in cranial neurosurgery where we have solid evidence about guidelines, what we should do and not. And still, there are open questions about timing, there are open questions about the tools. We all know that a tool alone is not enough. You need good decision making. You need to, look at the resources you have. And I think that discussion we had here in this forum tonight was a very good one for us to go back, discuss with our teams, right? Bring in new ideas. So I'm really happy for Dr. Lee to bring up this exciting lecture about what is possible. But at the same time, we discussed, right, how is daily life in ICH or daily nights. It's most often at night. So I think we all have a take-home message to digest and resonate with us. And I want to thank you again, Professor Raja, for this. I just looked it up, 377 session of ACNS webinar. This is outstanding. I have to echo Louis Bober. This is really outstanding. So really, this is something everybody's looking for, coming almost like a soap opera every month, coming back. This is amazing. I really enjoy that. You're muted.
Thank you very much. Like, it's a great honor for us to hear these words coming from great neurosurgeons like you. I must say, this is not a one-man show. This is like with the help of Dr. Lupun Singh, Dr. Ben, and under the guidance of Prof. Kato, we are extremely lucky to have her as a mentor, and we'll carry on further. We have, I'd like to thank all the 5 divisions of ACNS who contributes to the continuous webinars that we run every weekly and Saturday and Sundays. So thank you very much. So we'll come to the end of this session. I will close this officially now. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to thank both the speakers of today, Prof. Matthew Joseph and Professor Lee, as well as the chairs, Professor Ishwar and Professor Florian Roser, for the time and support for the ACNS webinars. A very special thanks to Prof. Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, we have around 945 people who have logged in through all the different channels. A special thanks to my co-host Lubun Singh for joining me today. And with that, I'd like to close this webinar until we all meet tomorrow online. Until then, it is bye-bye from all of us. Thank you very much for joining.